Good afternoon, everyone. It is now 2 p.m. I'm going to give everybody just a few more minutes before we actually start the lecture on what we're covering today. So let's hang out for just a few minutes and I'll be right back with you. Okay, it's now 2:02 going on 2:03 p.m. Today is April the 8th, 2024. And I'm going to get ready to share my screen. Okay, I'm sharing my screen with you. We're going to go over chapter 26 to begin with, abdominal emergencies. You know, abdominal emergencies are probably one of those lackluster emergencies that people have. You lack a lot of the excitement that we come to expect in EMS, but as you become more experienced as an EMS provider, you're going to understand that things aren't always lights and sirens, rush to the hospital. And sometimes you're going to experience the fact that what appears to be a boring run-of-the-mill call actually turns out to be something very serious. I'll share more on that in a minute. Today, we're going to talk about things like abdominal anatomy and physiology, abdominal pain and discomfort, types of abdominal conditions and assessments and care of the patient with abdominal pain or discomfort. So let's start right in the beginning with anatomy and physiology of the abdomen. It's very important to know what's involved or what organs are within the abdomen. And if you have a better understanding of those, you'll have a better ability to assess your patient. The abdomen contains many organs from several different body systems. You can always refer back to that chapter on anatomy and physiology. There could be some confusion when you determine the cause of an abdominal emergency because of the multiple organs within that space. The big key is thorough assessment, and you may not be able to come up with a specific diagnosis, and that may not be necessary. The treatment that an EMT provides is generally the same for most of those abdominal conditions. Now, where is the abdomen? The abdomen is the region between the diaphragm and the pelvis. And remember, the diaphragm is that membrane that separates the chest cavity from the abdominal cavity. It's also that membrane that contracts, helping to draw air into your lungs. We all know where our pelvis is at. The abdomen contains many organs that provide some of the following functions, like digestive, reproductive, endocrine, and regulatory organs. Let's talk about those. Okay, let's look at the organs of the abdomen. And if you can see my cursor, we're going to divide those into solid organs on the left side of your screen and hollow organs on the right side of your screen. Some of the solid organs are the spleen, the liver, the pancreas, and the kidneys. Okay. The hollow organs of the abdomen can include the stomach, the gallbladder, the duodenum, large intestine, small intestines, and the bladder. The abdomen is divided into quadrants. You've got the right upper quadrant, the left upper quadrant, right lower, and left lower quadrants. If you could imagine drawing an imaginary line through your umbilicus or through your belly button, that's how you divide that abdomen into 4 quadrants. And the 4 quadrants are used to describe and identify areas of pain, tenderness, discomfort, injury, or other abnormalities. Here's a picture of how the abdomen is divided up into the 4 quadrants. Now notice the right upper quadrant is on the left side of your screen, because whenever we do right and left in patient assessment, we're talking about the patient's right or the patient's left, not yours. Along with the organs of the abdomen, we've got a structure called the peritoneum. And that's a very thin membrane that lines the abdominal cavity and covers all the organs. The parietal peritoneum attaches to the outside of the body, to the abdominal wall, whereas the visceral peritoneum covers each individual organ. Most of the organs of the abdomen are enclosed within the parietal peritoneum, and a few lie in that extraperitoneal space, which means outside of the peritoneum. The kidneys, the pancreas, part of the aorta, they lie in the retroperitoneal space, which means behind the peritoneum. And the bladder and part of the rectum lie inferior or below the peritoneum. Okay, organs of the abdomen, continuing on, female reproductive structures and organs, they lie within the abdomen and the pelvis. Examples of those are the ovaries, the fallopian tubes, and the uterus. Some of the largest blood vessels in the body are located within the abdomen. Those blood vessels including the aorta, the inferior vena cava, the hepatic artery, the splenic artery, and the iliac artery and vein. Okay, here's a demonstration of peritoneal and extraperitoneal space. So we see all of this right here, if you can see my cursor, is the peritoneal space. And then what's outside of this space is extraperitoneal. Okay, notice right here we got the kidneys. Those are behind the peritoneum, so they're called retroperitoneal. So one of the things you're going to be called out for is abdominal pain or discomfort. And a lot of times, those are just very vague complaints, and you've got to build upon what the patient is telling you. Visceral pain can originate from within the organs of the abdomen. Now, there's fewer nerve endings, and they allow for only diffuse sensations of pain. Oftentimes, you're not going to have pinpoint pain. You're going to have more generalized pain within the abdomen. Sometimes and frequently, the patients describe this as dull or achy pain. You might have intermittent crampy or colicky pain that results in the hollow organs. And persistent or constant pain often originates from solid organs. Parietal pain originates from the parietal peritoneum. Many nerve endings are within the peritoneum, and they allow for pain that's easier to locate and describe. So a lot of this parietal pain is frequently described as sharp versus the dull, achy pain from deep within the peritoneum. The pain is often consistent or constant and localized to a specific area. Sometimes patients complain of tearing pain. Now, that's not the most common type of abdominal pain. Often originates in the aorta or in the stomach, and the separation of the layers of the aorta, such as caused by aneurysm, can be the cause. Retroperitoneal location of the aorta can sometimes cause pain in the back. They'll complain of back pain. Ulcers in the stomach are also a cause of tearing pain. Okay. So, if your patient's complaining of tearing pain, you are often dealing with pain caused by the aorta or stomach ulcers. Sometimes we have referred pain, and referred pain is when the patient feels pain or perceives pain in the skin or muscles at a distant location. There's some reasons for that. The abdomen has many nerves from different parts of the body system, and nerve pathways overlap as they return back to the spinal cord. So pain sensation is sometimes transmitted from one system to another. Give you an example. I had gallbladder problems years ago, eventually ended up having it taken out, but I would have left shoulder pain from my gallbladder. And the gallbladder is located in the upper right quadrant of the abdomen. Talk about some abdominal conditions. How about appendicitis? We've all heard of that, and that's simply an infection of the appendix. Signs and symptoms of appendicitis can include nausea, sometimes with vomiting. Pain is often initially referred to the umbilical region, followed by persistent right lower quadrant pain. Now, if the appendix ruptures, you'll have a sudden increase in severe pain, and the contents releasing into the abdomen cause severe peritonitis. So anytime you have one of these hollow organs rupture, they will leak their contents out into the peritoneum, and the peritoneum gets really, really inflamed. Peritonitis is an irritation of the peritoneum, usually caused by foreign material in that peritoneal space. The parietal peritoneum is sensitive, especially to acidic substances. So let's say we have a perforated ulcer and you were leaking hydrochloric acid into your abdomen. Of course, that's going to hurt. But if you leak blood into the peritoneum, that's going to hurt as well. If you have a leaky bowel, maybe somebody has a perforated bowel, so you're going to have feces floating around inside of the abdominal cavity, and that's going to cause you a lot of pain. Okay, irritation often causes involuntary contraction of the abdominal muscles. Signs and symptoms of that include abdominal pain and rigidity. Sometimes these people will draw their knees up. They will draw their knees up to reduce some of that pain and discomfort. Some people call this the fetal position. But by drawing the knees up and not wanting to straighten out, the patient will try to relieve some of their own pain. So that's something to really consider as you assess your patient. Okay, speaking of gallbladder problems, it's cholecystitis or gallstones. Cholecystitis is the inflammation of the gallbladder. It's often caused by a blockage of bile flow by gallstones. Okay, bile is produced by the liver, flows through the bile duct, is stored in the gallbladder until it's released later to help you digest your food. Okay, if the bile duct gets stopped up, not only does the gallbladder get irritated, but sometimes that bile can start backing up into the liver and into the pancreas, and that'll cause additional problems. Okay, the signs and symptoms of cholecystitis are severe right upper quadrant or epigastric pain, and pain is often referred to the shoulder. So I talked about back when I had gallbladder problems, I would have shoulder pain, but I would also have epigastric pain. Epigastric pain is at almost pit of the stomach pain. Pancreatitis, it's another abdominal problem. It's caused by an inflammation of the pancreas. It's common in patients with chronic alcohol abuse, and the signs and symptoms are epigastric pain. It's often referred to the back or shoulder. Let's talk about GI bleeding. And GI bleeding is a real serious problem. Bleeding within the GI tract, that's bleeding from anywhere from the esophagus to the rectum. It may be a minor bleed or it could be a severe bleed, but simply the presence of the bleeding itself makes this a medical emergency. I'm going to pause just a second while they set off the rescue squad alerts. All right, I apologize for that just for a second. GI bleeding within itself is a serious problem. Now, the blood eventually exits from the body. So it either exits the body through the mouth or the rectum. Oftentimes, GI bleeding, which is bleeding into the GI tract, not bleeding out of, but bleeding into the GI tract, is painless. Gastric ulcers can cause severe pain and peritonitis, but the GI bleeding into the GI system itself is usually, like I said, painless. Signs and symptoms of GI bleeding: dark colored stool. Some people talk about tarry stools. So if the feces is dark and tarry, then you've got a symptom or a sign of GI bleeding. Frank blood from the rectum. Now, it's not some guy named Frank, but frank blood means this is visible red blood from the rectum. Vomiting of a coffee ground appearing blood. Vomiting of frank blood. And with that, the pain's absent to severe depending on where you're leaking. Um, Oftentimes, the feces will be a really foul smelling. They'll smell really bad as well as look bad. Now, the closer you are to the exit, the more or the brighter the blood's going to be, the more blood-like it's going to be. Whereas if you're bleeding from near the center of your digestive tract, the blood is going to be more digested. That's where you get that dark tarry stool or the vomiting of a substance that looks like coffee grounds. But the brighter and more evident the blood is, generally the closer to the exit. Okay, let's talk about the abdominal aortic aneurysm. That occurs, and I'll tell you what it is. It's a ballooning or weakening of the inner wall of the aorta. It tears and separates from the outer walls, and this is called dissection. The weakened vessel does start to bulge, and that bulge may continue to grow, and it may eventually rupture. Now, this is very similar to, guys, we've had tires on cars that will develop a knot on the sidewall. I'm sure we're all used to that. And that ballooning or bulging out is very thin. It's much thinner than the intact wall of the tire or the intact wall of the aneurysm. As the bulge grows, it may eventually rupture. So here are your signs and symptoms. Progressive, often sharper tearing abdominal pain. It frequently radiates to the back. Rupture causes rapid onset of excruciating abdominal and back pain. Signs of shock are usually present, and you do have possible inequality of your pedal pulses. So if you palpate the pulses of the feet, they're not going to be quite as strong. One may not be as strong as the other. Okay. When this rupture happens, guys, you're probably going to die. Your patient's probably going to die. Tell everybody a little story about an abdominal aortic aneurysm patient that I contacted many years ago. The original call to the residence was for an elderly male who had passed out. We got there, sure enough, we had an elderly male who was lying on the floor. He was extremely weak. He was no longer unconscious. He could talk to us, but he obviously didn't feel well at all. When that happened, or what was happening, was he would his abdominal aorta swelled up. There was a mass or bulge that came on the side of that abdominal aorta. So you can imagine it's round, and then all of a sudden it grows. In essence, his blood pressure dropped because his body felt like his blood volume had dropped. We took him to the hospital. We followed up on the patient. He had been flown by helicopter to another facility with a diagnosis of dissecting AAA, or dissecting abdominal aortic aneurysm. The gentleman comes home. I'm going to close the door here, but the gentleman came home several days later. And since this gentleman's condition was inoperable, he was placed in hospice care at home. We received a call probably within the week that the gentleman had died. And what had happened, he was walking through the house with the help of his home health nurse. He sat down in a chair in the living room. The abdominal aorta ruptured at that point, and he bled out. He bled out to inside of his body. When we transported the body to the funeral home later, you could see all of the bruising or the presence of blood in his abdomen, or I'm sorry, on the side of his abdomen. Let me see. Okay, I'm fouling up here if I don't do this right. There we go. I'm not the computer guru that I wish I was. Anyway, the gentleman's aorta ruptured, blood spilled out into the peritoneum. It kind of leaked around, and you could see bruising in the side of his abdomen as a result. But he died instantly. Okay. Another abdominal issue that we're going to talk about is hernia. And a hernia happens when there's a hole that forms in the muscular layer of the abdominal wall. That allows tissue or parts of organs, commonly the intestines, to protrude up against the skin. May be caused by heavy lifting. Okay, may be caused as a postoperative surgical complication when the abdominal wall muscles aren't closed and don't heal correctly. Now, this may cause strangulation of tissue or may cause a bowel obstruction. So let's say we've got a loop of bowel that gets squeezed through this hole in the abdominal wall, through the muscles. So now this loop of bowel is stuck between the muscle and the skin on the outside. In addition, the hole that the bowel has been pushed through may be pretty tight. So the hole, the actual hernia itself, may squeeze off and block circulation to that tissue or bowel. When that happens, the tissue will die due to lack of blood, but truly more because of lack of oxygen supply to the tissue. We got to have oxygen in order to live. This can also result in a bowel obstruction, which means the bowel is blocked. These require transport to the hospital for evaluation if someone calls you for it. Signs and symptoms of a hernia include sudden onset of abdominal pain, often following lifting. There may be a palpable mass or lump on the abdominal wall or crease of the groin. Palpable means you can feel it. Okay, there's an issue called renal colic. Renal colic is severe flank pain caused by kidney stones traveling down the ureter. Signs and symptoms include severe pain in the flank or the back. That pain frequently radiates to the groin, and you can also have nausea and vomiting. Okay? Some chest or some abdominal pain may actually be chest pain, may be cardiac related, such as pain from a myocardial infarction, which is being felt as abdominal discomfort, such as epigastric pain or indigestion or digestive discomfort. Okay. So always consider the possibility of a cardiac emergency as a cause of abdominal symptoms. Sometimes abdominal pain is also associated with the female reproductive system. The most serious cause of that is ectopic pregnancy. Ectopic pregnancy occurs when a fertilized embryo implants outside of the uterus. The rupture can be life-threatening because it causes internal bleeding. How are we going to differentiate between all of these abdominal conditions, we may not be able to, but we are going to assess your patient. That'll help us. We're going to provide care for that abdominal pain or discomfort patient. Even though we may not have a definitive solution or definitive treatment, we can try to help them feel better and we can transport them safely. Okay. There are many potential causes of abdominal pain, and the role of the EMT is not really to diagnose exactly what's going on here. We want to focus our efforts on performing a thorough secondary assessment, and we want to focus our efforts on identifying serious or life-threatening conditions. As always, we're going to do our scene size up. We're going to protect yourself from vomiting as part of our scene size up. Okay? So when we say we're going to protect ourselves, especially when we protect ourselves from vomiting, you may need to have gloves as a bare minimum, as well as a mask or face shield, and possibly a gown to protect yourself from vomiting. This is a little warning here on the PowerPoint. Be aware of odors. Odors may help you, maybe an assessment clue, but this is also a warning. You may enter into a situation with some very nasty odors, and you just need to be prepared for it. Okay? You also need to determine if your patient's condition is a medical problem, a trauma problem, or both. Do your primary assessment. Get your general impression. How does the patient look? What position are they in? Consider their level of consciousness. Do we need to do some sort of airway care? If you have a patient that's vomiting, you do have an airway compromise or potential airway compromise. So maybe that patient either needs to be sat up in a position where they can clear their own airway or laid on their side. Okay. Look for those early signs of shock. That's a rapid, thready pulse. Also, cool, clammy skin. Position your patient, like I'd already said. If they're shocky, we want to try to lay them on their left side. If they're not shocky, we may want to set them up. We may want to put them in the most comfortable position for them, so long as the airway is not compromised. Consider application of supplemental oxygen if the patient is hypoxic, or in any situation where you believe that the oxygen saturation might be inaccurate. Why would the oxygen saturation be potentially inaccurate? Well, if you've got a shocky patient, then your pulse oximeter may not get a good and accurate reading. Okay? We're going to do a history of the present illness. Onset. When did it begin? What are you doing? Provocation. What makes it better or worse? Movement or position. Quality. Describe the sensation in your abdomen. When we talk about quality, we're talking about terms like burning, stabbing, dull, achy, or pressure, just that type of terminology. We're going to ask the patient about the region or radiation. Point to the location. Where does it hurt? Does the pain move? Does it radiate out or does it stay put? Severity. How bad is the pain on a scale of 1 to 10? And time. How long have you had the pain or discomfort? How has it changed? We're going to ask some female-specific questions. When or where are you in your menstrual cycle? Is your period late? Do you have vaginal bleeding that's not menstrual bleeding? And if you are menstruating, is your flow normal? Now, some of those are uncomfortable questions to ask, especially for some of us guys, more so than some of the ladies who are EMTs, but still, these are questions that you're going to have to ask. Vaginal bleeding outside of the menstrual cycle is generally abnormal. It's not normal. Okay. If a period is late, there's a potential that you have got a pregnancy, even though that pregnancy is not where it is supposed to be. Other female specific questions. Have you had this pain before? If so, when did it happen? What was it like? Is it possible that you are pregnant? And are you using birth control? We're going to get the past medical history. This is where sample comes in. Allergies. We're going to ask about medications. We're going to ask about past medical history, last oral intake, and events leading up to the emergency. When we deal with geriatric or elderly patients, there's a decreased ability to perceive pain. That's something you need to remember. A lot of times, the causes of abdominal pain in elderly people are very serious. It's more likely to be life-threatening in an elderly patient. And your condition, as well as the patient's condition, as well as your assessment of the patient, can be complicated by their medications. So we're going to physically examine the abdomen. And the first part of a physical examination is inspection. We're looking for distension, discoloration, and protrusions. So we're going to look. Then the second part, we are going to palpate. We are going to feel. We're going to use our fingertips. We're going to palpate the painful area last. Because if you palpate the painful area first, you may create pain all over. Okay. We're going to feel for rigidity. Are the muscles in the abdominal wall rigid? How does the patient describe the pain when you palpate? And are they guarding? Are they trying to protect that abdomen? Those are things you want to find out. We're going to get our baseline vital signs, and then we're going to repeat them every 5 minutes, because abdominal emergencies, even though they're kind of boring on the outside, can be very serious conditions. We're going to get the pulse, respirations. We're going to measure blood pressure. We're going to check skin color, temperature, and condition. We're going to check pulse oximetry, and we're going to keep an eye on the mental status as well. If the patient's mental status starts to deteriorate, that kind of makes this a greater or bigger emergency. Oftentimes, we have a hard time diagnosing abdominal issues. A lot of times, the complaints are very vague. But general abdominal distress sometimes results from digestive system disorders, or others could be cardiac or diabetic issues, food poisoning, flu. Always assess and care for these patients with appropriate attention to the airway. Again, particularly if the patient's vomiting. Always work to calm the patient to reduce anxiety, and never give your patient anything by mouth. You could complicate further assessment, or you could make the situation that much worse. So patient care, we're going to maintain our airway. We're never going to get away from maintaining airway. Be prepared to suction your patient if necessary. We're going to administer oxygen to the patient if they are hypoxic. Means we're going to maintain an oxygen saturation of about 94% or better. We're going to place the patient in the position of comfort. LLR, that's left lateral recumbent or shock position for airway protection. We're going to transport to the closest appropriate facility. So here's a scenario. Think about it. You have an 89-year-old female with a history of diabetes, hypertension, gallstones, and is complaining of nausea and dizziness about 20 minutes after eating. So what are your concerns with this patient? I'm going to be concerned about, number one, level of consciousness and airway protection. But I'm going to determine, is this an abdominal emergency, a diabetic emergency, or a cardiac emergency? And I'm going to know this because I'm going to perform a thorough assessment. That's going to include vital signs and blood sugar along with palpating the abdomen. Our treatment is always going to be based upon our assessment findings. Okay? To review some things out of the chapter, all patients with complaints of abdominal pain or distress should be transported to the hospital. These cases are difficult to diagnose without the testing resources that are available at the hospital. When you bring this patient in, the doctor is going to order lab work. The doctor is probably going to order an EKG to rule out cardiac issues. And the lab work can work on cardiac issues as well. But then they're going to order x-rays and other radiologic types of tests so they can see what's going on inside of the abdomen. As an EMT, your responsibility is primarily to assess the patient and report your findings. Diagnosing the cause of an abdominal complaint in the field is often more difficult and time-consuming than diagnosing in the emergency department, where there are many more resources. Truth is that physician is not going to be able to do the complete workup, the complete assessment on patient out in the field. If it was a doctor responding to the call rather than an EMT, the doctor is still going to rely on stuff that's there at the hospital, but not present in the ambulance. So don't be down on yourself. Always, your assessment should include a thorough history, good physical exam, and vital signs. Look for signs and symptoms that can signal serious trouble. Sudden onset of tearing pain radiating to the back. Okay, that's might clue us in for a dissecting AAA. Vomiting blood or coffee grounds like material. Okay, that's a signal of a very serious GI bleed. Presence of black tarry stool also indicates potential GI bleed, and signs and symptoms of shock in general. Okay. Emergency care will consist of protecting the airway, providing oxygen, placing the responsive patient in a position of comfort, or placing the unresponsive patient or patient with difficulty maintaining an airway in the left lateral recumbent position, and transporting the patient to the hospital. Remember, take all appropriate standard precautions and carefully clean and disinfect the ambulance, especially if the patient has vomited or had diarrhea. Other things to remember: abdominal organs provide a variety of important functions to the body. Okay? Now, if we had a live studio audience, as they might say on the Today Show or the Tonight Show, we had a live audience, I would ask and solicit questions. So let's move on to our next chapter. Okay, hang on, Albert. I don't know what I'm doing wrong. Okay, we are going to talk about chapter 27, behavioral and psychiatric emergencies and suicide. Topics we're going to be covering are behavioral and psychiatric emergencies and emergency care for behavioral and psychiatric emergencies. Okay. So what is a behavioral emergency? Well, behavior is a manner in which a person acts or performs. Behavioral emergencies is behavior within a given situation that is unacceptable or intolerable to the patient, the patient's family, or the community. Now, when we're doing that, that's recognized cultural behavior. Some cultures have people who are much more emotional than the standard Western civilization. So just be aware that some people are much more emotional, some cultures are much more emotional. Behavioral conditions require a full patient assessment because it may not all be behavioral or mental health related. Always try to remain objective. Sometimes it's very difficult to keep your thoughts in check while you're assessing your patients. Okay. Talk about behavior and brain chemistry. The observable behavior is largely controlled by neurotransmitters inside the brain. Neurotransmitters travel from the neuron to neuron. Impulses move across the nervous system by this mechanism. The neurons or nerve cells are long cells that come in contact with each other end to end, but there is a neurotransmitter and sometimes neurotransmitter chemicals in between those nerve cells. So if those chemicals get out of regulation, you can alter how the body works, how the neurological system works on a chemical level. Okay? Neurotransmitters or the lack of neurotransmitters have been implicated in depression and other behavioral and psychiatric disorders. Sometimes medications are prescribed for these conditions. Newer medications offer reuptake inhibition of more than one neurotransmitter. Okay, that gets a little bit complicated. Let's talk about psychiatric conditions. Some behavioral emergencies are caused by psychiatric conditions. It's a mental disorder. Almost 1 in 5 adults in the United States have some sort of mental illness. Mental health services are declining or they're overcrowding. In this country, more patients with mental illnesses are in the community with minimal treatment. And that makes it more likely that you'll be seen as a patient by EMS providers or EMS systems. Years ago, folks with mental disorders were rounded up and locked into asylums. And there was very little interaction between the mental health patient and the community. It's not so today. Sometimes there's physical causes of altered mental status as well, though, and we talked about those a couple chapters back. There's medical and traumatic conditions that can alter a person's behavior, such as low blood sugar, lack of oxygen, stroke or inadequate blood to the brain, head trauma, seizures, mind-altering substances, environmental temperature extremes. Now, you got to rule some of these conditions out as you assess your patient. We're going to talk about situational stress reactions. Remember, normal reactions to stressful situations produce emotions. So if you are stressed, you may end up with fear. You may experience grief. You may experience anger. You may experience anxiety. And a lot of us do that quite often. Okay? When you're caring for patients with situational stress reactions, try not to rush. Reassure the patient that you're there to help. Try to remain calm and keep your emotions under control. Listen to your patient. Be honest with them, but stay alert for changes in behavior. Talk about a condition called acute psychosis. That involves a severe break in the patient's abilities to process information and react with their environment, often associated with psychiatric disorders such as schizophrenia. Now, bad joke and probably bad form on my part. Way back when I was in nursing school, we had a sweet little instructor that said, "Can anyone spell schizophrenia?" And my response was Crazy. That was not an acceptable way to answer that question. As I've got older and more experienced, I'm not going to answer the question the same way. You cannot simply put everybody in the same box and say they're crazy. Acute psychosis symptoms are hallucinations, delusions, catatonia, and thought disorder. Okay? Hallucinations are seeing or hearing things that aren't really there. Delusions. These can be wild or extreme thoughts, such as, "My name is Prince Albert. I'm from England, and I go to the can very often." No, delusional thinking. Maybe folks believe that he is the king, or your patient believes that he is Elvis. Back many years ago, we had a gentleman who would rotate between being Jesus and Elvis. We called him Jesus Presley. He would preach for us and he would sing for us. He was having a psychotic episode. Okay. Catatonia, that refers to just kind of being out there and non-responsive or non-communicative. Also, people can also have thought disorders such as extreme paranoia. Be sure to ensure the safety of the patient and the responders. You may need extra help on standby, if nothing else, just in case this patient does get out of hand and create a situation that becomes dangerous to either you, the community, or the patient themselves. So how are we going to assess these patients? There's going to be a wide range of presentations. Some of the patients may be withdrawn and not communicating, such as catatonic. They may be talkative or agitated. They may have some bizarre or threatening behavior. Maybe the patient wishes to harm themselves or others. Key techniques in doing your assessment. Identify yourself and your role. "Hi, I'm Albert. I'm here with the ambulance. I'm here to help you. Can you tell me what's going on today?" Listen. If you're going to ask questions, you better listen. And sometimes you need to listen to the information that you're not asking for as well. Try not to be judgmental. The more judgmental you are, the greater difficulty you will have in completing your assessment. Try to use some positive body language. Get down on the patient's level. Acknowledge the patient's feelings. Don't enter their personal space. Stay at least 3 feet away from the patient. That gives you a little escape time. Be alert for changes in emotional status. That patient could be very cooperative, very easygoing, and then all of a sudden they start to either speak quickly or speak more slowly. They tense up and they're ready to fight. Use restraints to prevent harm if necessary, but be very careful with restraints. Know your local protocol. And in reality, you're better off letting law enforcement handle patient restraint. That reduces some of your personal liability. Okay. Slide on interacting. Plan your approach to the patient in advance and remain outside the range of the patient's arms and legs. Example, as you approach the patient or before you approach the patient, you've determined who is going to control which arm and who is going to control which leg if the patient decided to become violent. As you do your patient assessment, perform a very careful scene size up. Are there any weapons or objects present that could be used as a weapon? Identify yourself and your role as a provider. Complete the primary assessment. That is, what is the general impression of the patient? Do you see any obvious life threats? Perform as much of a detailed examination as possible. And that's as much as the patient will allow you to do. Gather a thorough history. Common signs and symptoms that we're looking for is panic or anxiety, unusual appearance, disordered clothing, poor hygiene. This is normal for some, but not normal for others. Agitated or unusual activity, unusual speech patterns, bizarre behavior or thought patterns, suicidal or self-destructive behavior, violence or aggressive behavior, all things to look out for. With your patient care, be alert for personal or scene safety problems. Treat any life-threatening problem you come across. Consider both medical and traumatic causes of this condition. Spend some time talking to your patient. Encourage your patient to discuss their feelings, but never play along with hallucinations. Maybe consider involving some sort of family or friend of the patient, someone that the patient trusts, someone that they know. Let's talk about suicide for a few minutes. Suicide is the 10th leading cause of death in the United States. Many times, depression is coupled with successful suicide has reached alarming levels in combat veterans and senior citizen populations. So a lot of combat veterans are bad to commit suicide, as are senior citizens. Many more people suffer both physical and emotional injuries in unsuccessful suicide attempts. My mother has a neighbor whose grandson attempted to overdose and kill himself. Now he has he is essentially mentally retarded now. He has caused enough brain damage that he cannot function as a normal person would. Okay? Anyone may become suicidal if emotional distress is severe, and people attempt suicide for many reasons. Potential or assisted suicide or attempted suicide explores some possibilities: depression, high stress levels, recent emotional trauma, age 15 to 25, and over 40 are the highest risk age groups. Drug or alcohol abuse can also increase your chances of wanting to commit suicide. Potential or attempted suicide explores some possibilities such as threats of suicide, suicide plans, previous attempts or threats, sudden improvement from depression. So we've got a sudden improvement. I know it's going to be okay now because I'm going to die. First concern must be your own safety. Do your emergency care. You do a scene size up. Identify and treat life-threatening problems. Reassure your patient. Perform a secondary assessment and detailed exam if it's safe. Reassess frequently and notify your receiving facility. Okay, let's think about it. Patient is a 23-year-old male. His girlfriend called 911 after a domestic dispute. He is uncooperative. He is refusing treatment. The girlfriend reports the patient is depressed and suicidal. He owns a gun and has threatened to shoot himself. Things to consider. Can you treat him if he did not call? Very possible, But that is my advice is to leave that to law enforcement. If anybody's threatening to shoot themselves, law enforcement needs to be involved. Should we believe the girlfriend? And I think this is happening more and more in America. If you want rid of somebody, claim that they're suicidal so that the police will take them away. If your boyfriend or husband is a fan of owning a lot of guns, likes to collect and shoot guns like a lot of us do, what better way to hurt them than to claim that they're mentally unstable so that the authorities remove their access to firearms? Kind of like taking a kid's cell phone away from them. Okay? Does the patient need treatment or transport? Maybe. Depends on your assessment. Can you treat and transport the patient against his will? I'm not going to. Because he hasn't done anything yet other than he is alleged to have made this threat. What should you do? Contact law enforcement. That's what you should do. I'm going to take a little break and cut my lights on because the eclipse is coming up on us. Go get it. I'm doing lights in here. Just go on through. Okay, sorry about that. Let's talk about aggressive or hostile patients. Consider the clues. Consider your dispatch information. Consider clues from the scene. Clues from the scene might include weapons or objects that can be used as weapons. Dispatch information. What did the patient tell them? Information from neighbors, families, and bystanders, and the patient's stance or position in a room. Make sure you have an escape route, just in case things go bad. Do not threaten your patient. You're going to get on this cot or I'm going to whip your butt is not an appropriate way. I'm going to see you in the nut house. We're going to take you to the mental hospital if you don't cooperate. Don't do that stuff. Stay alert for weapons of any type. Patient assessment. Don't proceed beyond primary assessment until the patient is calm or restrained. Primary assessment is assessment for life threats. You may spend most of your time trying to calm your patient down and ensuring everyone's safety. You may spend a lot more time doing that than you're going to spend actually treating your patient. Hostility and aggression are never an excuse for not assessing a patient as thoroughly as possible. So if he calls you a fat SOB, you still have to assess your patient. Okay, emergency care, perform a scene size up, request additional help if necessary. If I've got a mental health call, I'm probably going to request law enforcement to be en route. Seek advice from medical control if necessary. Watch for changes in behavior, sudden changes especially. Reassess frequently. Consider restraints. Now let's remember reasonable force and restraint. And reasonable force is defined as a force necessary to keep the patient from injuring himself or others. Reasonable is determined by the patient's size and strength, the type of behavior, the mental status, the available methods of restraint. Now, something that you might want to consider with determining reasonable force. Who the patient is and who you are. Give you some examples. I weigh in excess of 300 pounds. The amount of force that I can utilize in dealing with a patient is determined in part by how big that patient is. So here's a 300-pound male versus a 90-pound elderly lady. The amount of force I can use is going to be much less than if I'm dealing with another male who is my size my age, my weight. In most localities, restraint is within the jurisdiction of law enforcement. Always involve law enforcement with these situations if you can get them. Never attempt restraint without proper legal authority and sufficient assistance. Let's talk about excited delirium. Excited delirium is extremely agitated or psychotic behavior. Triggers for this condition can include uncontrolled psychiatric illness and or drug intoxication. These patients frequently develop significant or even life-threatening cardiovascular and metabolic stress. We've heard this term a lot in the news here within the past couple of years, and there have even been EMS personnel sentenced to prison now for killing a patient while they were attempting to restrain him with medication. So be very, very cautious. So remember, the term is positional asphyxia. Inadequate breathing or respiratory arrest caused by a body position that restricts breathing. Example, hog tying your patient. You cannot hog tie a patient. You should not restrain a patient face down, and you definitely should not sit on his back while you've got him restrained face down. Also, carefully monitor restrained patients. Do you want the patient to be able to get loose? No, but you've also got to make sure that the restraints aren't so tight that they injure the patient as well. If you're going to restrain a patient, you need to have adequate help. You need to plan what's going on. Plan how you're going to do it. Stay beyond the patient's reach until you're prepared to take action. Act quickly. One EMT needs to be the person that talks to and calms the patient down. To do it correctly, you're going to require at least 4 persons, one at each limb, and you're going to restrain all limbs with approved leather restraints in the supine position. Supine means on the back. Remember, when you restrain a patient, when you reduce their ability to care for themselves, you have now assumed responsibility for that patient's safety and well-being. You are responsible for that restrained patient's airway. You are responsible for making sure that they are adequately secured throughout the transport. If the patient is a spitter, you can apply a surgical mask over the face or a commercially prepared spit hood if your local protocols permit. Reassess that patient frequently, document thoroughly, explain what you did and why you did it. Transport them to an appropriate facility. Here's some medical legal considerations. Consent. Refusals and restraints can create significant legal and medical risk. Laws typically allow providers to treat and transport patients against their will if a danger to themselves or others, but know your state law on treating patients without consent. Sexual misconduct. Beware, behavioral patients sometimes accuse EMS providers of sexual misconduct. If possible, have a same-sex provider attend to the patient. For the aggressive or violent patient, make sure law enforcement officers accompany you to the hospital. That protects you and the patient. And in the event of a legal problem, they can serve as a third-party witness. Chapter review. As an EMT, you respond to many behavioral emergencies. Be sure to ensure your own safety before entering a scene or caring for a violent or potentially violent patient. Considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. It's important to remember that patients in crisis are patients. They're people who need your help. They need your compassion as well as your care. Always consider patients acting in an unusual or bizarre fashion to be experiencing altered mental status. This will help you to avoid overlooking a medical or traumatic cause for the patient's problem. Okay, now, unusual actions I would hate to be accused of going against or violating a patient's rights and harming them by restraining them and hauling them to the hospital for a psychiatric condition when the problem was really low blood sugar. So always assess your patient along the altered mental status route. A lot of these patients require long-term help, but how you handle yourself can be crucial for the patient's continued well-being. Okay, remember, safety is the first priority. Psychotic and behavioral emergencies are prevalent in our society. EMT should treat them as they would any other potential life-threatening disorder. Assessment of altered mental status should rule out physical causes first. Psychiatric and behavioral emergencies can present differently depending upon the disorder. There are best practices EMTs can employ in approaching, assessing, and treating such patients. Always follow your local protocols. Okay. That topic is over. Behavioral and psychiatric emergencies, guys, can be really, really difficult to handle, difficult to assess. And sometimes your success in handling these emergencies depends on your ability to control yourself, to control what you say and how you act, to control yourself to the point that you can stay on task and do what the patient needs versus allowing your emotions to get out of line and allowing your preconceived thoughts to interfere. Okay, let's go to chapter 28. Hematologic and renal emergencies. Okay, there's the topics: hematologic system, renal system. Talk about the hematologic system. That's the blood. The blood is basically its own organ system, has specific functions. The blood controls bleeding by clotting. The blood delivers oxygen to the cells, removes carbon dioxide from the cells, delivery and removal of other waste products to organs that filtrate and remove them. Hematologic system is also made up of solid components: red blood cells, white blood cells, platelets. Those are suspended in the blood plasma. Medications can affect some components of the blood. What happens in blood clotting? Well, this happens when aggregation of the platelets, is the body's most rapid and initial response to stop bleeding. Clotting factors are a group of proteins produced in the liver and released into the bloodstream. Once activated, the clotting factors form clots through what's called clotting cascades. Coagulopathies. It's an abnormal clotting of the blood. Can occur when the body forms clots too readily or the patient clots too slowly. Certain diseases make the patients prone to poor clotting, such as advanced liver disease. Remember, the clotting factors were produced within the liver. Also, hemophilia or von Willebrand disease. Identifying patients' coagulopathies. Certain medical conditions in which the normal ability to form clots can worsen the patient's disease. An example of this is patients with prescribed blood thinners. People who take prescribed blood thinner medications are more prone to have life-threatening bleeding when injured than patients not on these medications. Well, let's go back for just a second and remember what we talked about earlier when it comes to GI bleeding. GI bleeding can be very severe. I know of a situation where a lady who was a home health patient of mine, I had to go by her home and draw her blood at least weekly to monitor the clotting factors in her blood. The clotting time is what we were actually monitoring. The patient was on Coumadin. Well, the patient was changed from Coumadin, which was an old-fashioned blood thinner, to a medication called Xarelto, a more modern blood thinner medication. Well, this patient got up one morning, cooked breakfast for her entire family, and then went to the bathroom and started passing blood through her bowels. Then she started to vomit blood. She was dead by evening. Apparently, that Xarelto medication had worsened a GI bleed, and as a result, she bled to death. So that's how GI bleeds are particularly bad. So really pay attention to that and be aware that blood thinners can make some problems worse, even though they're designed to treat other problems and make them better. Okay, emergency care. Take appropriate standard precautions. If it's wet and it's not yours, don't touch it. Protect yourself from bloodborne pathogens. Gloves, masks, eye shields, gowns. Okay. Perform primary assessment and care for any immediate life threat. Obtain a history from the patient and identify which specific blood thinning medication he or she is taking or which bleeding disorder he suffers from. Notify the hospital as early as possible. Continuing with emergency treatment, monitor patient for the development of the signs and symptoms of shock or decreasing mental status. Administer supplemental oxygen if the patient appears to be in shock or has a decreased mental status. Transport to an appropriate receiving hospital. Let's talk about anemia. Anemia is a lack of a normal amount of red blood cells in circulation. Acute anemia can be caused by sudden blood loss, but very often we will run into patients or encounter patients with chronic anemia. They have recurrent heavy menstrual periods or slow GI bleeding or a decrease or diseases affecting bone marrow or structure of the hemoglobin. Maybe sickle cell anemia. Sickle cell anemia is a genetic disease that affects the red blood cells. Most often occurs in patients of African descent. The defective shape resembles a sickle. So instead of making a full circle, the red blood cell looks like a comma. The cells have a short lifespan, and that leads to chronic anemia. Complications of sickle cell anemia include destruction of the spleen, a sickle pain crisis, acute chest syndrome, priapism, stroke, and jaundice. It's estimated that 1 in 13 African Americans has the sickle cell trait. Having the trait doesn't always lead to complications, and it's possible to lead a normal life with that trait. If your patient's having these problems, administer supplemental oxygen, monitor for inadequate respirations, monitor for signs of hypoperfusion, and hypoperfusion is simply body-wide poor circulation or shock, and transport to a stroke center if you suspect a stroke. Talk about the renal system, components of the renal system. You've got 2 kidneys, 2 ureters, 1 urethra. Okay, you've got a kidney on each side normally. Each kidney is attached to a urethra or a ureter. Those ureters drain to the bladder. The bladder drains out of the body through the urethra. Kidneys are essential for your life. The kidneys filter blood that by removing certain waste products, excessive salts, excessive fluid. The kidneys help maintain your fluid balance. So you neither have too much nor too little fluid. Diseases of the renal system may affect different portions of the body, and they can range from minor to life-threatening. Urinary tract infections, that's something you're going to experience, or something that your patients are going to experience. Urinary tract infections, or UTIs, are the most common disease that afflicts the renal and urinary system, usually caused by bacteria, usually limited to the bladder, and cause pain and frequent urination. If they're left untreated, they can result in a disease called pyelonephritis. What happens? The UTI, the organisms will travel up the ureter into the kidney. So urinary tract infections are not always kidney infections, but they can result in kidney infections. The urinary tract infections are better named bladder infections than kidney infections. Okay, kidney stones. Kidney stones are usually made of calcium and formed within the kidney. When they're in the kidney, they're inconsequential. They have no symptoms. When they become dislodged, they can cause severe unilateral flank pain because those kidney stones are sharp, and as they move down the ureters, they will cut and abrade the interior surface of the ureter, and that results in pain. Patients may report nausea and vomiting. Let's talk about urinary catheters. You're going to see a lot of patients with urinary catheters. And reasons for a urinary catheter include obstruction of the bladder outflow or a neurologic disorder, which prevents emptying of the bladder. These patients use urinary catheters to drain urine out, commonly inserted in the urethra, but may be placed through the skin, such as in the case of something called a suprapubic catheter. The use of catheters is down as compared to 10 to 20 years ago, because we have learned that urinary tract infections can be a complication of the use of a urinary catheter. You're introducing organisms into the urinary system via the catheter. Also, think about when you transport a patient who has a catheter with a drainage bag, keep the catheter below the level, or keep the drainage bag below the level of the bladder so that urine doesn't flow backwards. If urine starts to flow backwards up the tubing and into the catheter, back into the bladder, you're going to introduce a lot of microorganisms. Talk about renal failure or kidney failure. Yeah, that occurs when the kidneys lose their ability to adequately filter and remove toxins. Sometimes you can have acute renal failure. That results from shock or toxic ingestion, or chronic renal failure may be inherited, may be secondary to damage from uncontrolled diabetes or high blood pressure. End-stage renal disease, ESRD, is irreversible renal failure, requires dialysis. 2 types of dialysis: hemodialysis and peritoneal dialysis. 90% of dialysis patients receive treatments a week. Okay, lasting 3 to 4 hours. Only about 8% treat themselves at home. ESRD patients often rely on EMS for transport to and from dialysis. However, that has been decreasing as your private ambulance services seem to have taken advantage of the situation for many years and transported a lot of folks to dialysis who did not require ambulance transport. Simply a way to take a little extra money from Medicare. With hemodialysis, the patient's connected to a dialysis machine that pumps blood through specialized filters. Two large catheters, and all a catheter is a tube. A urinary catheter is a tube into the bladder, whereas these dialysis catheters are tubes into the circulatory system. They create a circuit by which the blood is removed from the body, filtered, and returned over several hours. There is a slide of how hemodialysis works. Two types of access for blood circulation with hemodialysis: a two-port catheter or an AV fistula. If you ever have a patient who is taking hemodialysis, ask where the access is. Some of them have a access basically near the collarbone or in the groin, but the vast majority have this AV fistula, which is arteriovascular, arteriovenous fistula. Some people call it a shunt, but ask those patients where it's at so that you're not taking a blood pressure in the same arm with a AV fistula. You'll be able to feel blood travel through the fistula if you palpate it. It's kind of neat. Okay. Here's that two-port catheter inserted near the collarbone. And here is an example of a surgical fistula. So the doctor cut up here at the top, cut down at the bottom, fed this tube, which is made of Gore-Tex, the same substance that's in waterproof boots, attached to an artery, made a loop around and attached to a vein. The needles that are used for hemodialysis are inserted in both sides of this fistula. Peritoneal dialysis is a totally different animal. It uses the peritoneal cavity's large surface area. There's a special fluid that's introduced into the abdominal cavity. It's left for several hours, and while that fluid is in there, it's absorbing waste and excess water or fluid out of the body. Then the fluids are moved and discarded. A lot of people do this at home, but in order to perform this at home, generally the patient has got to have a clean environment and a competent helper or caregiver. Two types here: continuous ambulatory peritoneal dialysis, gravity exchange process repeated several times a day, or the continuous cycler assisted peritoneal dialysis. That machine, there's a machine used to fill and empty the abdominal cavity while the person sleeps. This is more common. Here's a peritoneal dialysis catheter. Emergencies with end-stage renal disease. Two different types of emergencies, broad categories that you may run into. The first one is emergencies that arise from the loss of normal kidney function. And those are the types of emergencies that dialysis is supposed to help prevent. The second type of emergency that you're going to see in end-stage renal disease are emergencies that are complications related to the dialysis treatments. A large number of dialysis patients, remember this, a very large number of them have other underlying diseases such as diabetes and high blood pressure. That's how they got here to begin with. Most complications of ESRD relate to the patient missing dialysis. These patients will present with signs and symptoms similar to CHF, shortness of breath, edema, and electrolyte disturbances. If your patient has missed dialysis and they're calling you, what are we going to do? We are going to assess ABCs. We're going to obtain vital signs, place them in a position of comfort, administer oxygen, consider use of CPAP if that's within your agency protocols, monitor vital signs closely, and have your AED ready, transport to a facility capable of dialysis. If you have that capability within your area. A lot of our rural areas will just simply have to transport to the closest appropriate facility and let that facility arrange transport to another facility where the patient can receive definitive care. There's some complications of dialysis, such as bleeding from the fistula site, clotting and loss of function at the fistula. Okay, so one direction or the other here, or bacteria infection of the blood due to contamination at the AV fistula or dialysis catheter site. Peritonitis, if you've got a peritoneal dialysis patient. How do we care for them? We're going to assess the ABCs. Control bleeding if it's present. We're going to use direct pressure, elevation, hemostatic dressings as needed. If bleeding can't be controlled by other means, a tourniquet should be applied. Administer oxygen. Treat your patient for shock. Keep them warm. Keep them supine. If peritonitis is suspected, transport dialysis fluid for confirmation if it exists. And we're talking about peritoneal dialysis fluid. Sometimes you end up with patients who have received kidney transplants. There's approximately 21,000 kidney transplants per year. It's the most commonly transplanted organ out there. Most of these patients spend their lives on special types of drugs to help prevent organ rejection. However, those drugs increase susceptibility to infection. Nothing's perfect. So let's review our chapter. Blood delivers oxygen to the cells, removes carbon dioxide, controls bleeding by clotting. Blood consists of what? Of red blood cells, white blood cells, platelets, and plasma. Anemia is simply a deficiency of red blood cells in circulation. Sickle cell anemia is an inherited disease, results in the hemoglobin being misshapen, can cause blood clots, blockages in smaller vessels, causes chronic anemia, and also sickle cell anemia causes a decreased ability to transport oxygen within the body. Renal system comprised of the kidneys, the ureters, the bladder, and the urethra. Kidneys perform a vital filtering of the blood to remove waste products, also help maintain a water balance within the body. Problems with the renal system include infection, kidney stone, renal failure. Renal failure is a condition where the kidneys are unable to filter waste and provide a balance of fluid and electrolytes. Dialysis removes those excess fluids and electrolytes from the body by filtration. Dialysis can be performed as hemodialysis or peritoneal dialysis. Hemodialysis is generally performed 3 times a week in a dialysis center, whereas peritoneal dialysis is usually done at home and done several times a day. Most complications in patients with end-stage renal disease can occur after the patient has missed dialysis appointments. They can occur from infections or as a result of bleeding from the hemodialysis access site. Remember, blood has specific cellular components. Abnormal blood cells can significantly affect patients. The renal system is critical to maintaining homeostasis, keeping the body's functions in balance. Renal failure can be chronic or it can be acute. Chronic means long-term. Acute means sudden onset. End-stage renal disease is managed through dialysis. Here are some questions. Does my patient have a history of sickle cell disease or ESRD? Does my patient have an AV fistula? And will I need to make an early request for ALS because of complications from a missed dialysis appointment? Critical thinking. You have a patient who's transported routinely for dialysis 3 times a week. She was sick, excuse me, and canceled the trip yesterday. Now she calls saying that she can't breathe and feels like she's going to die. Is it possible that she has a legitimate complaint after missing dialysis by only 1 day? It is possible. Okay. So that's leave. I'm going to stop sharing. I'm going to finish up here. Abdominal emergencies and hematological emergencies can sometimes be a little less than interesting or a little less than exciting, but nonetheless, these are very important topics to understand. We're going to treat our patients appropriately. We're going to assess our patients appropriately. When we deal with behavioral and psychiatric emergency patients, we are going to do our best to assess the patient, to do it well, and to be a friendly and nice acting care provider so that we don't complicate the situation. As always, if you have any questions for me, if you have any concerns about your class, reach out to me by email. Everybody's probably got my phone number. You can text me. You can call me. Also, on Thursday, we will be meeting at the Breaks Park at noon. That's Thursday, the 10th. Plan to be there from noon to 4 p.m. Additionally, I want to make sure that everybody is taking care of getting their ambulance right along time so that you're not out in the cold come the end of class. That is one of your requirements to successfully complete the course. If you're having any problems with that, please reach out to me and I will try to make some arrangements to see that you have somewhere to go ride. Well, thank you, everybody, and I will see you next time.